there is a tendency to want to overinterpret the results of a randomly collected urine sample. And I'll give you an example of what people would really, really like to hear from me. Let's say someone has a positive result on an oxycodone, regardless of the result, say a positive oxycodone result. What they would really like me to tell them is, yes, your client is positive for oxycodone because she took 10 milligrams of oxycodone at exactly 2:35 yesterday afternoon. And moreover, the oxycodone tablet was purchased at a Walgreens drugstore at the corner of 145th and Aurora in Seattle, Washington, and the pill was manufactured at a pharmaceutical plant in some city in New Jersey late in the fall of 2015. It would be kind of nice if I could tell you that kind of information, but unfortunately I can't. So, most, if not all, of the routine drug testing that's performed on urine samples is performed on a randomly collected urine sample. What I mean by that is there's some sort of a numbers program or a colors program, some sort of random number generator that determines when and how frequently an individual is asked to go produce a urine sample. So when that urine sample is produced and we look at the results, there's a lot of things that we don't know. First of all, we don't know when the drug was used, if it was used. We don't know how much drug was used. And we don't know if the patient is using the drug as prescribed or potentially abusing the drug or a substance. So with that, I think as we go through, I'm going to do the presentation sort of a question and answer format, because a lot of the things I'm going to be talking about are questions that I get asked or questions that our client services group is asked, and I'll present the answer and then discuss a little bit about why we can or cannot answer that question. But the first question that gets asked is, how much drug did my client use? That's very difficult, if not impossible, to answer, because there's so many things that we don't know. First of all, we don't know when the drug was used, and if we look at the concentrations in the urine sample, the concentration of the drug is dependent upon the creatinine concentration. So whatever the level of drug in the urine sample is, it really doesn't correlate very well with what the level might be in blood, and it certainly doesn't correlate with the amount of drug that an individual might have used. Now, look at the next slide, and this is a drug elimination curve, and this will explain a little bit about why we can't answer a lot of the questions. This is basically a drug elimination curve. At time zero, an individual takes a drug. This can be any drug, because this elimination curve applies to virtually every drug that we're going to be considering. As the individual uses the drug, either smoke, snort, whatever, doesn't matter, the levels in urine initially rise, they reach a plateau, and then they're eliminated at various rates. So if a sample is collected at time point A, we go up here and we see one concentration. It's relatively high. If we collect the blood sample at a later time point, like here, then we see this is the concentration here. Now the concentration of drug is very, very different at these 2 points. But the amount of drug that was used was the same. The only thing that's making a difference in the concentration of drug in that urine sample is the time of sampling. So it really depends on when the sample is collected in terms of what kind of a result you could expect. So you can get multiple concentrations of a drug in a urine sample just depending upon the time frame in which it's collected in relationship to when the drug was used. So quantitative levels really don't mean very much, other than to say that the higher the level, probably more drug was used, or the higher the level, more recently it was that the drug was used. So the next question that often comes up is, I've got a positive for drug XYZ on my client. he or she claims that they used the drug at such and such a time. Can I verify when did my client use that particular drug? Well, again, it's very difficult to give an exact answer to this question. What we can give you, though, is we can give you an approximate window of detection for drugs. This is based on normative value that's been collected in a large number of individuals. It depends, when the individual used the drug depends a little bit on how much drug was used. The more drug that was used, the longer it's going to possibly stay in their system. Another question that enters into the equation is how frequently was this particular drug used? Because there can, for many, many drugs, there's a cumulative effect. If they're using on a regular basis, the levels go up higher until they're eliminated. And finally, the level of drug in the urine sample depends upon the creatinine concentration. If you have a very concentrated sample, i.e. the creatinine level is high, then whatever drug is in that sample is going to be concentrated to the same extent. And if you have a very dilute specimen, that is, the creatinine level is very low, basically meaning that there's a lot of water in that particular sample, the level of drug is going to be commensurately low. So it's very difficult to answer exactly when did my client use a particular drug. The next couple of slides shows approximate windows of detection in urine samples. And again, these are approximations. The metabolism of drug varies from an individual to an individual, depends on their renal function, their liver function, among a lot of factors. And as I mentioned earlier, also depends upon how concentrated or how dilute the particular sample is. If the sample is particularly dilute, the window of detection may be shorter. If it's more concentrated, you might be able to detect the drug for a little bit longer. But approximate windows of detection. So for amphetamine, methamphetamine, the maximum window of detection is approximately 2 to 3 days after last use. It's gone pretty quickly. For ecstasy and its primary metabolite MDA, ecstasy is MDMA. Again, very similar to amphetamine and methamphetamine, the window of detection is approximately 2 to 3 days. For opiates and opioids, the approximate window again is approximately 3 to 5 days. And this is pretty much standard for most of the opiates and opioids that we might be encountering. There might be a few exceptions, but for the most part, this holds. Now, however, if someone is using heroin, and we're monitoring heroin use with the heroin biomarker 6-acetylmorphine, the window of detection for 6-acetylmorphine is very, very short, probably not much longer than 12 to 16 hours after the heroin was used. So opiates and opioids, 3 to 5 days. Heroin, very short, 12 to 16 hours. For cocaine, approximately 2 to 3 days. However, if an individual is a chronic user of crack cocaine, the window of detection may extend from 7 to, in some cases, 10 days. PCP, phencyclidine, approximately 7 to 10 days after last use. Now, marijuana presents a very interesting story because marijuana can be stored in adipose tissue. Adipose tissue is fat cells, and regardless how thin or how heavy an individual is, we all have fat cells. We all have fat cells. So THC, the active ingredient marijuana, can be stored in fat cells. The approximate window of detection for casual users, these might be party users, an individual who uses smokes marijuana on a very intermittent basis, like on a weekend party or something like that. The window of detection can be relatively short, anywhere from 2 to 7 days after last use. There's an urban myth out there that anyone who takes a single puff on a marijuana cigarette is going to test positive for up to 30 days after that single puff. That just isn't true. Most people, regardless of their use, are going to be negative for marijuana within approximately 2 weeks after their last use. Now, there is a unique group of individuals who are chronic users of marijuana, and this can be classified as someone who's a daily smoker for a very, very long time. Well, chronic users of marijuana may still test positive for up to 4 to 5 weeks after their last use. And what accounts for that? Well, as I mentioned earlier, THC is stored in fat cells, adipose tissue. So once an individual stops smoking marijuana, they've got stored THC in their fat cells, and the fat cells are slowly leached out of the fat cells, gets into the bloodstream, and then is eliminated in the urine. So 4 to 5 weeks to test positive after last use for chronic users is not unusual. And I've seen a few cases where individuals still test positive for up to 6 to 8 weeks after last use. That's obviously a rare individual, but I have seen that. For ethanol, this is alcohol, ethyl alcohol, the type of alcohol that humans consume. In urine, the window of detection is relatively short. In most cases, not much more than 12 to 16 hours. Now that window can be extended if someone is really drinking a large quantity of alcohol. But in general, 12 to 16 hours is the approximate window of detection for alcohol. Now, if we look at ethyl glucuronide and ethyl sulfate, and I'll be talking a little bit more about these two biomarkers later on. If you recall, ETG and ETS are minor metabolites of alcohol that we use as biomarkers for alcohol consumption. The window of detection for ETG and ETS can be as long as 72 to 96 hours after an individual has stopped using alcohol. Now, this window of detection is obviously dependent upon the amount of alcohol that's used and also on the frequency of alcohol that's used. If someone had 1 glass of wine 24 hours earlier, it may not be detected in a specimen collected 24 hours later. However, if an individual drank a bottle of vodka, they're probably going to be positive for ETG and or ETS for up to 3 to 4 days after they finish consuming that bottle of vodka. For methadone, methadone is another opioid. Methadone is a little bit unique in that it has a considerably longer window of detection. It has a window of detection approximately 5 to 7 days after last use. Benzodiazepine or the Valium type of drugs can have window of detection anywhere from 3 to 14 days, depending upon which benzodiazepine has been used. A very short-acting benzodiazepine like midazolam may only be detectable for 2 to 3 days after use, and a long-acting benzodiazepine like Valium or diazepam, the last metabolite of diazepam or Valium, which is oxazepam, that can persist for up to 14 days after last use, and in rare instances it can be detected for a little bit longer than that. It would be exceptional, but you can see it. For the barbiturates, again, there's a large class of barbiturates. They're classified either as short-acting or long-acting. Short-acting barbiturates like pentobarbital may only be detected for 2 to 3 days after last use. A long-acting barbiturate like phenobarbital may be detected for 14 days or occasionally a little bit longer in individuals who use phenobarbital. So there's, in summary, in terms of window of detection, the window of detection can be quite long for some drugs, very short for others, and the numbers that I proposed here are obviously averages that have been collected from epidemiological type study. So we can give you an approximation. We can't tell you within a very, very narrow range of time when particular drugs might have been used. Then this is what we call the addiction question. We get asked this all the time. Is my client addicted or dependent upon drugs? And the reason this question is usually posed is that an individual may have particularly high levels of a particular drug. Let's say someone consistently tests high for a drug like, let's say, hydrocodone. And the question is my client addicted or dependent upon this particular drug? Well, unfortunately, the biochemistry doesn't help us very much. Addiction or dependence upon a particular drug is strictly a clinical diagnosis. It is not a biochemical diagnosis. Individuals trained in addiction treatment or chemical dependency professionals can make a clinical diagnosis, but this is not done on biochemical diagnosis. Yes, you might get a hint if someone is constantly testing at very, very high levels for a particular drug. That's sort of suggestive that they're using a lot or maybe using more, but that is not a definitive way to make that particular diagnosis. Here's another very common scenario having to do with false positive results. We get telephone calls all the time. The scenario goes something like this. Well, I know that pseudoephedrine is a drug known to cause false positive results in the amphetamine methamphetamine screening enzyme immunoassay. I have a client that screened positive for amp meth, and she's claiming to have used an over-the-counter decongestant that contains pseudoephedrine. Since she's been using pseudoephedrine, is it safe to assume that the positive screening result is from the over-the-counter medication? Well, unfortunately, you can't tell for certain. It's absolutely necessary to do confirmation testing. Confirmation testing is necessary to rule out a false positive screening result. If you were to accept this excuse, well, I'm screening positive for amp and meth, I'm using a decongestant that contains pseudoephedrine, this is basically giving them a license to use drug without being held accountable for what they're doing. So even though we know certain drugs have a propensity to result in false positive screens, it's absolutely imperative confirmatory testing be performed to completely rule out any kind of a false positive. Prescribed drugs. An individual tests positive for a particular drug, and the question is my client using the drug as prescribed? Again, a random urine sample doesn't help. You may have high levels, but this really doesn't tell us any indication whether the individual is using the drug as prescribed. If we go back and look at that drug elimination curve, I think it's pretty apparent from that the level of drug really depends upon the time when a particular sample is collected, and the concentration in urine sample can vary with time after collection. So it really doesn't help us at all in telling us whether a client is using a drug as prescribed just from looking at random urine samples. It just doesn't help. Here's an alcohol question. My client has a urine alcohol level of 278 milligrams per deciliter. What is the blood alcohol level? Unfortunately, we can't tell. There is a very, very poor correlation between urine alcohol concentration and the blood alcohol concentration or the breath alcohol concentration. On randomly collected urine samples, it's very, very difficult to calculate what the blood or breath alcohol was with any type of certainty, and I certainly do not advise trying to do that. It just doesn't work very well. Okay. The next couple of slides have to do with ETG and ETS. I spoke a little bit about them earlier on what the windows of detection are, but just as a reminder, ethyl glucuronide and ethyl sulfate are minor metabolites of ethyl alcohol, or ethanol if you will. They're formed in the liver, and they are biomarkers of ethyl alcohol exposure. ETG and ETS are very, very sensitive and very, very specific markers for ethanol exposure. Other alcohols like methanol, which is found in a lot of industrial solvents, does not result in positive ETG or ETS. Methanol exposure results in the formation of methylglucuronide and methyl sulfate. Isopropyl alcohol, which is the primary component of rubbing alcohol, Again, rubbing alcohol is isopropyl alcohol, and someone exposed to rubbing alcohol would produce isopropyl glucuronide and isopropyl sulfate. So again, ETG and ETS are very specific markers for ethyl alcohol exposure, and none of the other alcohols will result in positive ETG or ETS result. Going back to what was asked earlier, my client has a positive ET/ETS level. What is the blood alcohol level? Well, we cannot determine that at all. ETG and ETS are metabolites of alcohol, and there is absolutely no correlation between alcohol levels and ETG and or ETS. So you can have a very high ETG/ETS, and the urine alcohol would be non-detectable, as the serum alcohol could also be non-detectable. The big difference is the window of detection for alcohol in urine, blood, or breath is relatively short, whereas the window of detection for ETG and or ETS can be very, very long. So there's absolutely no good correlation between the levels of ETG, ETS, and ethanol. So we cannot make this sort of a determination at all. Similar question relating to other drugs. My client has a positive ETG/ETS test. How much alcohol did she consume? Again, ETG and ETS concentration do not correlate with the quantity of alcohol consumed. The other factor to be considered when you look at ETG/ETS levels is the relative dilution or concentration of a urine sample can and will affect the ETG/ETS level. Just to give an example of this, the next slide shows data from a drinking study that I performed many, many years ago in Tacoma. I recruited 9 individuals who I asked to consume 3 alcoholic drinks of their choice. This could be 3 beers, 3 wines, or 3 mixed drinks, whatever they considered a normal drink. These individuals did it in the presence of their home. They weren't driving, so it was done under very safe conditions. And I asked each individual to collect every random urine sample after they consumed the alcohol, and these are the results. There's quite a bit of variation in the absolute levels, ranging anywhere from over 100,000 to down into the tens of thousands. And so the whole point of this slide is to show that there's a lot of individual variation in the response to a given amount of alcohol that's consumed. And there's also considerable variation in the levels of ETG that one can see. So the correlation between ETG and the amount of alcohol consumed is a very, very poor correlation. So we can't tell from an ETG or an ETS level how much alcohol was consumed. Another common question regarding addiction or dependence. My client has very high levels of ETG and ETS. Does that mean that he or she is an alcoholic? Again, the diagnosis of alcoholism is a clinical diagnosis. It is not a biochemical diagnosis. There are very qualified chemical dependency counselors or drug treatment counselors can make the assessment of dependence upon alcohol or any other drug. Again, the diagnosis of alcoholism is not a biochemical diagnosis. The ETG, ETS levels cannot help you make that diagnosis. Now, if someone has chronically very, very high levels of ETG, ETG, this might be suggestive of consumption of a large amount of alcohol, but the definitive diagnosis of alcoholism or alcohol dependence, again, is a purely clinical diagnosis and cannot be made on any type of a biochemical analysis or diagnosis. Another question about alcohol and impairment. My client had a very high ETG, ETS level. Was that individual legally impaired? Well, the legal definition, or the legal per se definition of impairment due to alcohol is a blood alcohol concentration or a breath alcohol concentration in excess of 0.08%. As I mentioned earlier, ETG and ETS levels do not correlate with the amount of alcohol consumed, nor do they correlate with the BAC or the breath alcohol concentration. So an ETG-ETS level cannot be used to determine impairment. At the time the urine sample is collected, the ETG-ETS level may be very, very high. At that point, when the sample is collected, the individual may be very, very sober, shows no sign of impairment, but that doesn't tell us anything what might have been the case 24, 48, or 72 hours earlier. We just cannot make that type of determination from ETG or ETS levels. Another ETG question, ETG-ET question. My client has positive ETG levels, and he admits to drinking a few beers. Are low positive levels of ETG-ETS consistent with only drinking beer? Well, alcohol is alcohol regardless of the source. The ETG-ETS result cannot differentiate between beer, wine, vodka, whiskey, mixed drinks, or even NyQuil. Any substance, beverage, food, otherwise, that contains alcohol, the alcohol is absorbed, it gets to the liver is exposed to the alcohol, and in response to alcohol exposure, ETG and ETS are synthesized, are formed, and they're excreted in the urine. So ETG, ETS cannot, I repeat, cannot distinguish between the type of alcohol, whether it's from beer, wine, vodka, or anything else containing alcohol, even NyQuil, or if an individual is exposed through, say, hand sanitizer or alcohol-containing mouthwash, the ETG test will not tell us that. What the ETG-ETS test will tell us is that individual was exposed to alcohol. Now, the concentration will help us determine whether it's from incidental exposure or whether it was due to voluntary exposure to alcohol, but it does not tell us what type of alcohol the individual was exposed to. So, based on what I have just said, it almost sounds like there's not a whole lot we can tell from a urine drug test. Well, that's not entirely true. But you know, from a very simplistic and basic point of view, what do positive results from a randomly collected urine sample really tell us? About the simplest conclusion that one can draw is the donor is using whatever their drug they tested positive for. This could be amphetamine, methamphetamine, cocaine, one of the opiates, one of the opioids, alcohol, the barbs, the benzos, whatever drug it is that they test positive for. The simplest explanation is the donor is using the drug. If you do multiple testing on the same minute, you might be able to garner some more information, but the simple answer is a positive drug test result primarily means that the donor is using that particular drug.